Our next panel is taking a look at the clinical perspective. Where do we see population health going? Our moderator is Marty Woodruff. He's our Associate Director at MiHIN, where he provides essential leadership and client management skills. He has over 28 years of experience in information technology. Marty directs the day-to-day production systems to ensure all MiHIN services remain fully operational and in production at all times. Prior to working at MiHIN, Marty was the Director of Clinical and Business Operations for Great Lakes Health Information Exchange, overseeing the integration of new healthcare delivery and business systems. In addition to his time there, he also served as a practice manager at Liaisons Health. Marty will be moderating our next panel. Please join me in welcoming them to the stage.
Thank you, guys. So, good afternoon. Thank you all for joining us. Today we're going to take a look at different perspectives. We have accountable care organizations, clinically integrated network, and other risk-bearing organizations, and how they function within the healthcare ecosystem. Today we have three wonderful guests who have agreed to join us, all of which I've worked with in various capacities. First, we're going to start with Terrisca. Terrisca, again, a pleasure to see you. Terrisca is a recognized leader and an innovator in the healthcare industry, as evidenced by her many and varied professional experiences. She's publications, speaking engagements, and local and national awards. She is currently, today, the administrator for Physician Organization of Michigan Accountable Care Organizations, the PM ACO. It's one of the nation's largest Medicare shared savings programs. It manages over $1 billion of healthcare spend yearly. She also serves as advisory consultant to the Greater Detroit Area Health Council, and recently finished serving as one of the 7 National Bruce Bradley Fellows for the Leapfrog Group. So we will begin with Terrisca, if that's acceptable. Please.
Well, thank you for the invitation to present today. Really appreciate it. And as Marty opened up, I'm Terrisca Jardins with the Physician Organization of Michigan, Accountable Care Organization. We refer to ourselves as PM ACO. Some call us PM ACO. Either way is fine. Purposes of PM ACO, we founded ourselves in 2012. We're majority owned by the University of Michigan. I joined the team about 2 years ago. In 2012, the group decided that they wanted to pursue Track 1 Medicare Shared Savings Program Accountable Care Organization with CMS. So I think everybody's at least somewhat familiar with the ACO program in that it supports the triple aims of healthcare. The purpose is really to develop a more integrated approach to healthcare delivery across a disparate group of providers. We at PM ACO really only provide just a very thin layer of administrative infrastructure at the central ACO office in Ann Arbor. There are about 12 of us there. That includes about 4 data analysts, a few project managers, an agreement coordinator, and a couple of administrative folks, along with a couple of part-time executive physician leaders, and really rely on our physician organization partners to carry the heavy water buckets in their local communities working with providers. We are physician governed and led. Our governing board is comprised of physician leaders from all over the state of Michigan. Our chairperson of the board is Dr. Tim Peterson. He's an emergency room physician with the University of Michigan. So here are all of our partners, and our partners are our owners. Like I said, University of Michigan is the majority owner of PM ACO, but we have 10 owner organizations across the state of Michigan. These organizations, I think, will be recognized by just about everybody in this room. So we cover the entire state. We have beneficiaries in all 83 counties, as well as serve beneficiaries in every single state in the country because of travel patterns and the like. But you can see that we serve patients and providers in urban, rural communities, and everywhere in between. And so we think that this provides some significant challenges to us, but I think it's also our strength because we learn lessons from one another. The cultures of both the patients and the providers are very different across the state, and we think that that's an advantage that we have in terms of being able to learn about what works in one community can often work in another. So like I said, 2013 was our first performance year. This year we have approximately 5,200 healthcare providers across the state. We have around 73,000 Medicare beneficiaries. That's a significant reduction from years past where we've been at around 6,000 or so providers and well over 100,000 patients. And we saw a drop in participation this year for a couple of different reasons. We've been instituting more requirements for participation over the last couple of years, and also the advent of the Comprehensive Primary Plus initiative influenced some of our providers' decision to leave the ACO because CMS sometimes doesn't always align programs. So providers have to leave a significant amount of money on the table if they're with an ACO and CPC Plus. So we did contract a bit this year. We are still one of the largest Medicare Shared Savings Program ACOs in the country relative to both the number of contracts we have in place with our providers as well as the beneficiaries and our total spend. We've saved nearly $60 million for taxpayers over 4 years, and $12 million of that we were able to achieve in shared savings to redistribute to our provider network. Here are just a few statistics about our performance. 2014 was the year we were able to distribute shared savings. We did start with a relatively low benchmark at the outset of the ACO, which makes it a little bit more challenging to continue to improve every year over year against our own performance. And so last year we saved $8 million. The prior before that was 17.7. In 2013 was 4.7. And although we achieved savings in those years, we did not jump over that 2% savings threshold to be able to distribute shared savings. The Michigan Medicine Quality Department, through a master services agreement, provides our data analytic support services. This includes downloading all of the claims data that CMS provides us on a monthly basis for all of our patients. We process the data and create separate data files for each of what we call quality review organizations, but you can just read this as physician organization partners to be able to use that information for care improvement with their particular provider population. We also create patient-level and summary reports on certain metrics of interest for PM ACO and distribute those to the quality review organizations, again, physician organizations. And new to 2018, we're offering a new tool in Tableau for additional levels of analyses. In previous years, our reporting was really only at the ACO and QRO levels. And while we provided detailed reports to all of the individual physician organizations, each one of them has a different capacity to consume that data and then turn that into actionable information. And so the strategy was quite limited in terms of being able to provide actionable drill down reports. There was inconsistency, like I said, on the QRO ability to use the data. And just processing reports in PDFs and Excel spreadsheets was time intensive. So this year we are rolling out Tableau. I think everybody in this room is probably familiar with it. It is a little bit of a clunky tool, but for claims data, turning claims information into actionable information, I think it's quite adequate. It's a single point of entry for all of our ACO partners. We process cost, quality, utilization, and clinical initiative data, which we've done in the past, but again, in the past, it's really been at an ACO organizational level or physician organizational level. So now we're able to provide it to the practice, NPI, and patient level. PM ACO does not integrate clinical data at the ACO level. This isn't to say that our QROs or our physician organizations aren't using clinical data. Of course they are at the point of care. And our QROs, we do require them to participate in HIE. We don't dictate or prescribe what particular use cases or which HIE to engage with. We just ask them to focus on the areas that they need to improve upon. We also require our providers to use certified EHRs, and this was a result of MACRA and MIPS, and that with ACOs, you sync together, you rise together. So it is the way of the world, and we did lose some providers as we instituted this requirement, unfortunately, but the majority of the network wanted to make this move. We also support our annual quality reporting process. CMS asks us to pull clinical data out of the systems to support evidence that shows that we're providing appropriate high-quality care. And I can tell you that although we've tried to automate this process, last year we tried to do it for the 2016 performance year, and we weren't successfully able to pull data out of systems that, and 3 of the QROs are quite sophisticated in their use of the technology. 2 of them are employed groups. 1 is an independent group that has a central data repository. And we were only able to pull about 10% of the data that we actually needed to report to CMS. So, there's a lot of work that still needs to be done, making sure that, we were talking about this at our table over lunch, making sure that people are using their source systems, they know where to enter the data, they know how to enter structured data. We need to work with the EHRs and be able to pull the data that we need from a clinical perspective. We're not there yet. A lot of that work is grunt work. It's not glamorous, it's not the new shiny object, but that's the work that needs to be done in order to make what we've all been talking about today meaningful. On the horizon, we are, at the end of this year, going to be transitioning to a new risk model, Track 1 Plus, which means we take on downside financial risk. Under Track 1, it's been upside only. So that's going to mean some significant changes to our organization. I think we'll probably decline in size by about half of what we are today. Not all of the providers are ready to make that leap just yet. We do have plans to obtain clinical data to enhance our analytic offerings, and we're also pursuing additional analytic support services to be able to provide more information on specialist performance. A couple of the topics du jour that came up today that we are also working on. One, we just ran an opioid use report, and we're really not, to be quite honest with you, we're really not quite sure what to make of the data. Either we have a significant problem or maybe we don't have a problem at all. And there's a lot of debate around, what measure to use to really kind of assess where our patients are in their use of opioids. And, we talk a lot about patient use, but we'd also like to get to a point where we're also educating providers and making sure that, providers have appropriate prescribing patterns. The second topic I've noticed that's come up a couple of times is social determinants. And that's something that we are just beginning to work on as an ACO. A couple of our provider organizations are beginning to screen for social determinants and collect that data. We are finding, at least in the Medicare beneficiary population, and this is not surprising to me because we did some work a few years ago in Detroit where we found the same thing too, is that social isolation is a huge issue. And there really aren't very many resources to resolve that particular issue. So we're working with some of our health system partners on potentially creative financing options to open up opportunities for intervention around social determinants. Thank you.
Thank you. Next, we're going to hear from Gene Farber. He serves as Chief Operating Officer at Reliance ACO. A little bit about Gene. He's in charge of overseeing the day-to-day operations of the ACO. In addition to that, he's grown this ACO from 2014, starting at about 14,000 beneficiaries, currently hitting over 37,000 beneficiaries. No small feat there. And in addition to that, he has introduced and led the efforts to form a new next generation of ACO, the Reliance Next Gen ACO, congratulations, which was accepted into the program this year. So, Gene, please.
Thank you. And thanks for the opportunity to participate in this conference. It's great to see all the people here. As Marty indicated, we started in 2014. We are a physician-owned, physician-led and I'm the only non-physician in leadership in the ACO. We take a somewhat different approach than POM, and there's no right way to do things, there's just different ways to do things. We went starting with 100 physicians, and today, as Marty indicated, we've got 40,000 beneficiaries in the two programs. The Medicare Shared Savings Program, which is track one, same as POM, and the Next Generation ACO, which is a risk program. In order to be in that, you're eligible for 80% of the savings instead of 50%, but you have to pay 80% of the losses. We thought we were ready. We will find out at the end of the year if it was the brightest thing we did or the dumbest. In addition to that, we've formed a separate physician organization, Reliance Physician Organization, and we are managing what was formerly the DMC PHO, which is a separate physician organization. Among all of those groups, we have about 800 primary care physicians. We've saved over $29 million for Medicare since we started in 2014. We've saved money every year. We've distributed over $15.5 million to our doctor members. We take a much heavier hand than POM does. We have, in terms of quality, auditors that go out to all of the offices. We have physician liaisons that go out every single month to every office to talk to them about various issues. MiHIN has been absolutely the backbone of our operation. We started in 2014, and Marty will know I called plenty of times when I was not happy. We used the ADTs in a different way than most other ACOs. When we get the ADTs, which show admissions or a person touching the emergency room, we have staff from 7 a.m. to 11 p.m. that calls the emergency rooms. In addition, we text our doctors and hospitalists through a phone app that we have to notify them to try to prevent unnecessary admissions. Because we're physician-owned, we're hospital agnostic. We work with all of the major systems in the Tri-County area. We have physicians in 5 counties, Wayne, Oakland, Macomb, St. Clair, and Monroe. So there's separate hospitals in both, obviously, St. Clair and Monroe counties. Over the years, we have been able to get the hospitals to tag our ACO patients. We take the list that we get from Medicare, from CMS, forward it to the hospitals so that when our doctor or nurse practitioner calls and says a patient's there and they look in their system, they will see there's a little Reliance tag. That has taken years to get to that point. We've also been able to have access to the hospital EMRs so that we can see in real time the patients that are there. Sometimes because of matching, we don't get every single patient, and this is kind of a backup. Obviously, the biggest problem, and other speakers have discussed it, is the fact that there's no uniform way to identify patients. So if a middle initial is put in on one form but not on the other, it will not match. That's not unique to us. That's a system-wide problem. The previous speakers have gone through that, and hopefully that's something that we'll be able to do. We have a couple more years in the track 1, which will end in 2020, and that will be our 6th year in that. And at that point, we will have to decide whether it's a Medicare MSSP Track 1 Plus or some other form that we proceed on in the future. Our kind of core success has been based on physician participation, that they are invested both financially in terms of giving the funding to the ACO, and also hopefully emotionally in that they understand what we're trying to do as an ACO. And so far, it's worked. Thank you.
Next panelist is Abba. Abba is not only the CEO of MedNet One, but the founder. It was established in 1981, serves more than 900 primary care and specialty care physicians. Abba's organization is unique because it has incorporated behavioral health specialists into the fold as well. In addition to offering patient-centered medical home and patient-centered programming and transformation services for the last few years, Abba is also a recipient of the Eagle Award from the Greater Detroit Area Council. So, Abba, please.
Thank you, Marty. I'm going to take this conversation in a different direction. We are not an ACO. We are an independent physicians organization, so being involved a lot with CME, I'm going to go ahead and give you our learning objectives for this afternoon. So I'm going to talk about the HIT capabilities of our organization. I'm going to explain how those HIT services really impact not just our organization, but our partners, and then give you a little idea as to how care coordination events are really impacted by HIT. So I would be remiss by not telling you a little bit about the look back. So for those of you who have been around for a number of years, as our group has been, you'll know that personal computers and external hard drives were extremely expensive. So in 1981, we purchased a Sanyo computer, for those of you who may remember that, with 2 external drives, and we paid $15,000 for that. We then went ahead, because we're involved with the military, decided that the best computer to get was about the size of a current dorm room refrigerator. So we went out and bought a Plexus computer, and we were so excited because it had 1 gig of memory. And then we went further on. Blue Cross, I should say Blue Care Network at that time, said, we'll give you eligibility on a tape. So we would get these massive tapes, but then somebody had to read them. So we went out and bought, for those of you who know this, a Kennedy tape drive. That was another $30,000. And we were loading our eligibility, and we purchased some claims processing software. Lo and behold, it was actually developed for behavioral health organizations, and the only reason we bought it is because we were able to go ahead and attribute physicians to actual addresses. So if they had 10 addresses, we could do that. And then we began doing our own claims processing. So up until the turn of the century, which would be like 1999, we did our own claims processing for Blue Care Network, and we were pushing through a very sizable amount of claims, and we were able to begin looking at our own diagnosis codes. And we figured out that there was a huge problem. Chronic conditions began to rise, and we couldn't figure out what to do with it. So let's move forward to where we are now. We think data warehousing is new. Well, no, we did that back in like 1988, but we didn't know what to do with it. We also began to get all of this information from Blue Care Network, from Health Alliance Plan, from Select Care, for those of you who remember way back then. We still didn't know what to do with it. So we developed simple analytics. We developed our own quality improvement strategies, and we really began thinking about where to go next, created some dashboards with our partners at Blue Care Network. And for those of you who might remember this company, it was called ePhysician. They were the first e-prescribing program. We signed on board in 1999. They went bankrupt in 2000. But the unique thing is we found out where those faxes were going to at Farmer Jack's and different pharmacies. They were going to the deli department. So we had to send our staff out to go ahead and spend some time explaining to them what the significance was of getting that information back to where it needed to be. And I don't know if Dr. Simmer's here today, but if we're looking for a driver of change in the big challenge, I don't think there's anybody in this room who could really go ahead and say That was not the challenge. That was the challenge. That was the person who went ahead and made a huge difference in what we're doing today. Because the physician organizations, we were challenged to go ahead and do something different. Defy that status quo. We're not going to tell you how to do it. We're not going to show you how to do it. Figure it out. And for those of you that are in the 42 POs, you actually began to figure it out. And so this is what we were basically charged with. Figure out chronic conditions. What are you going to do with the data? What's the significance of this new thing called workflow? And how are you going to share this information internally and externally? Because up until PGIP, the only people that were actually giving us dashboards and scorecards and giving us information was Blue Care Network. And they would show up with this entire pile of things, and then we needed to figure out what to do. And this is our challenge. We're not an ACO, but we are an all-patient, all-payer organization. We go ahead and take anyone and everything. We create our own definite organizational leadership pool, which means we look at who comes on board and who really wants to move in that direction. We accept all healthcare providers. That doesn't mean that if your quality scores aren't good, we'll take you on board. When I'm referring to all healthcare providers, I'm talking about psychiatrists, psychologists, which are huge, limited licensed psychologists. We've brought in chiropractors, we've brought in podiatrists, we've brought in every single specialty, and we brought them to the table to say, what can we do for our patient population given the right data? We brought in payers. We've totally revamped the way in which we approach QI coaches. Anybody out here who's an RN, cover your ears. We no longer hire RNs to do our QI. We bring in MPHs. Our master's level public health specialists, we partner with Oakland University, are stellar. They can go out and they can crunch numbers and they can create trend reports, and they have moved us from where we were to where we are now in a very short period of time. And this is very important, the last bullet point. We're all innovators. You are innovators too. I hate to hear the little comment when people say to me, yeah, but, it's yes and. Yes and, when can we do this? And yes and, when is it going to make a difference? So this is what we've done. These are our challenges. You know, we really became reliant on technology. Our physicians are showing up with computers sometimes, and this is kind, you have to be very careful when you say this. So we have an internal warehouse, but it's truly a war house, because we use that to really go ahead and war with individuals in the community, because when they tell us you're wrong, we can provide them with information saying, you know what, we've got it right. And we identify those analytics that bridge. We're not looking for something different. We want something that works within. One of my staff, Mark Lazar, and our QI people go out, and we have bridges with almost every single EHR. So we do our own work, extract information from EHRs, and we're able to go ahead and say your data's wrong because we went ahead and extracted it on our own. This has been a huge event in what we're doing. So strategy to capture all of our data and analyze the data, you're seeing it. We no longer call it an EMR because it's not a medical record any longer. It's an EHR. And in that EHR, because we have our own internally, that does include pharmacy data. Very key for us. It also includes care management information. We're able to make changes in those areas because, again, analytics and the things that we have. Financials, yeah, we've got that too. That kind of ties in to everything that we're doing. But to us, that's, you flip the coin. For us, the important thing is clinical. And then if you do really well in the clinical area, the other part, the almighty Benjamin will take care of himself. We won't have to worry about that. And what all of us do a terrible job on right now is patient satisfaction. We're not collecting that data. We're not able to go ahead and really help those individuals that probably need the help most. So this is our HIT challenge, and this is how we've gone ahead and attacked it. We look at financial support. We've got some great partners. We know that there is income coming in because of the work we're doing. There are incentives. So those incentives and those financial items that we get from whether it's Blue Cross, HAP, and others, we actually invest that in our physicians. We don't give them the money. We tell them, you want to work with us, you need to have an EHR, you need to have a patient registry, you need to have somebody being your population coach, you need to have a care manager. So we're actually infusing information into their practices, and because of that, the analytics staff can really go out and make a difference. The worst thing to do, and Dr. Stefanik will agree with me, is you walk into a physician's office and you give them their data report. So what? It's like, yeah, I know, I need to lose 20 pounds. I know, what are you going to do to go ahead and help me do it? You have to go ahead and have an even keel where somebody really explains it. Our key partners in this entire journey has been MiHIN. If it wouldn't have been for MiHIN stepping up to the plate, we wouldn't have many things. We have a great patient registry. We're able to send information back and forth. We're able to create trend reports. We're able to take a look at our STARS rating. We're able to take a look at where we stand relative to other areas, including HEDIS. We rely on MQuick guidelines. Those are embedded in what we currently have. Our registries, we have inbounds. We also have outbounds. If you take a look at our outbounds, this is what we have. Thank you again, Blue Cross. You gave us the money to do this, so we're going to keep taking the whip out and telling you, keep giving us the money because it's working. So Blue Care Network, Priority Health, HAP, and other payers, they take advantage of this capability. Inbound, we get all labs. If you're with JVHL, we get it. We have a lot of interfaces, and again, we've gone ahead and created a generic interface allowing us to go ahead and capture this data. And our biggest partner is Patient Ping. I have no qualms about taking this and telling you that this is what has really made a huge difference in our organization, because what we're able to do is get real-time notifications. I did an interview this week with a publication, and I was asked not to use this example, but I will use it. And you may have heard this before. My father was being transferred from the hospital to a post-acute care facility. I'm sitting in a parking lot saying, this is impossible, they won't know. So I logged into Patient Ping, and as he's being wheeled up into a transportation vehicle in his wheelchair, there he is, and it's telling me what home care agency is stepping up to the plate, what DME is going to be working with him, and as a matter of fact, by that time, we even knew what care managers were going to link into him. Care transitions and information, MiHIN and Patient Ping, you've got this down. It's stellar. So now this is what we can do because of the tools that we have. These are electronic tools, demographics, insurance. You're looking at PCP attribution, care management information. The list goes on and on. So today there are even more enhancements with Patient Ping. We're a heartbeat away from collecting social determinants at the time of discharge. We're a heartbeat away from doing some other very innovative things with them because when we ask, they listen and they produce very quickly. So the impact of ADTs has been phenomenal, huge on HEDIS and STARS, but most important, it's been very, very influential in our area of ED visits because we know who our frequent flyers are. Just yesterday, we found a patient that came to us from another PCP. When we took a look, he had 14 visits in the ED in the last 3 months. So why? We would not have had that data before. We use this as a way in which to improve patient satisfaction and physician satisfaction. So I have to tell you how we can do this. When my team, and I should say not my team, when the Medical Network One team goes out and a physician says to us, so what's in it for us? We're going to go ahead and do all of this work. You guys are going to get all of this money. This is what we use as a bargaining chip. So if you are with PCHIP, and if you are a patient-centered medical home, you get a 10% uplift in your E&M codes, and we're able to monitor those E&M codes so we know what kind of revenue is being generated. Then you get an uplift for cost. It can be either 5, 10, or 15%. That's a lot. Then you take a look at your quality scores, that too, 5, 10, or 15%. And then take a look at the last 2 points. If you are engaged in population health and if you have a crackerjack care management team and that team has to include a behavior health person, RNs are great. You work on medical models. I'm looking for someone that will go ahead and create a true care plan that includes behavior health because we need to change behaviors. And unless we have this information, it's not going to happen. So imagine telling a physician you can get anywhere from 20 to 40% in an uplift in your E&M codes. We just had a meeting last week with about 39 physician practices. They didn't realize what those last 2 points were. We now have to hire additional 8 care managers in the next few weeks because they see that value. And again, it has to do with analytics. If you don't have the data, you can't do this because you have no way of showing it. So we basically showed them the numbers. These are your 2 procedure codes. Take a look at the difference in that fee schedule and what happens after the uplift, but you have to have the data, and you have to be able to show what's in it for us. So this is what we're working on right now. All of you know use cases. Marty knows, you know, and he just goes ahead and says, can you do this? And we go, yeah, just tell us when. So we were one of the first to be involved in the ACRES file. And again, we're a physicians organization, so we're doing all patient, all payer. There's a common key that people are working on now. We were very much involved with the ADT feeds. We get our CCDAs. We do medication reconciliation, but I have to flip that. It's medication identification at time of discharge and validation with what's in the physician's chart. Health directory, health risk assessment, we're part of the work group in the state of Michigan now. And we were also part of the PPQC program that's identifying a uniform metric adoption, which many of us struggle with a lot. So I keep going back to succeed at this, folks. It is IT, and you've got to do clinical in IT, and there needs to be like ambidextrous work, so when you're going in this direction, someone's going in this direction, but you're always working together. You know, best practices, I hear that all the time. God, they got best practices. I don't care about your best practices. Show me that those best practices are being used, they're implemented, and you've embedded them in your activity, not just showing what you can do. Show me you're using it every day. Collaborative learning. A lot of what we do in the IT world is because we work with other POs and we work with like-minded people. There is a group of 6 POs that meets every month to talk about tomorrow. Not yesterday, but to talk about tomorrow. We've got a lot of innovators. Our practices are ready to jump on board. They need financial support. Without that, it's just not going to happen. Major successes, you see this. This is, again, a part of what we currently do across the board with HIT. Would never happen if it wouldn't have been for MiHIN. And again, we look at all of our successes totally linked to MiHIN, totally linked to other organizations, because to achieve success, you have to have both the clinical side and you must have the HIT side.
So at this point, I would like to open it up for questions for any of the panelists. And I have to tell you, I'm blind up here. So I have a question for you. First of all, you all 3 have a different flavor, a different variation, but all 3 of you use the word use the data. How do you, some of you touched on it, but what's the trigger to getting the physician or sometimes office manager? I don't always like to pick on the physician, but how do you get that engagement at the practice NPI level to make the connection to the data that you give them to look for the change that's needed, besides the financial? Because sometimes financial is not enough. So can I start with you, Jessica?
Sure. I think there are a lot of factors that go into that, but I think for us, the use of physician champions and really having a conversation, not just sending out, practice support folks, and those folks are important too, but really having the conversation physician to physician. This is what we're seeing in the data. This is how you're comparing to your immediate peers. This is how you're comparing to who's in our physician organization, who's in the other physician organizations, and ultimately up to the ACO. Again, there's a lot more that goes into that, but I would say the physician champions and that one-on-one interaction at the boots on the ground level.
So I do agree with that, but trend reports really work. If you show somebody where they were 2 years ago and where they are now, very beneficial. And I have to step back and again remind myself quite frequently that it's not just the physician, but in a patient-centered medical home environment, you have standing orders. So it's the practice team that really can make a difference. Those team huddles make a difference. So during those team huddles, you show that data. And again, that patient-centered medical home model has really impacted our physician community more so than any other product in the state of Michigan.
I would agree and slightly disagree. I think the physician liaisons that bring out information to the offices are extremely important because the day-to-day running, as part of the team, as you pointed out, is done by the line staff. If the office manager is not on board, the quality measures are not going to be put into the chart, and it's not going to get done. On the other hand, it is critical, and we have a medical director that meets one-on-one with the doctors, because you're correct, just dropping off information is not doing it. The doctors have to see the trends. They have to see that they're spending more this year than last year, or that they're going in the proper direction, that their ED visits have gone down. And giving them information on the codes. The transition of care is incredible. We run out for each office on an NPI level how much they left on the table in 2017. And you go into an office and you say, there's $35,000 or $50,000 that you left on the table that you could have billed for. And by the way, if you would have gotten these people in that period, you probably would have prevented a bunch of rehospitalizations and made life better for the patient. So all of these things together, and repetition is critical. You can't go out once, you can't go out twice. It's got to be part of the process. As Eva says, it's got to be built in kind of to the DNA of the office, that this is what you do. And it takes time and it takes effort, and some of the offices will never get it. And one of the things that I think all of us have learned, that much as we'd like to have a really large organization, there comes a point when you have to say you're not meeting the standards that this organization has set, and we're sorry, but we're not going to continue with us. And we're doing that now. It's not an easy thing to do, but long term, I think it's absolutely critical.
Thank you.
Hi, Tom Simmer from Blue Cross. First of all, I just want to salute all three of you for your leadership and your innovation in moving population management forward so effectively. The one thing that really blew me away was the degree to which your population management efforts are now reliant on MiHIN and the health information that is shared across the state. My question relates to, we've heard a lot recently about paramedics stabilizing patients, coordinating care with the primary care physicians, and then not transporting to ED or hospital. And I was wondering if any of you have any experience with that as you manage the ACO populations or commercial populations, and do you have any suggestions for us, since we're starting to get into that rather intensively at the Blues?
So we haven't ventured down that path, but we are preparing ourselves to take advantage of the skilled nursing facility 3-day waiver, which allows patients not to have to spend 3 days in the hospital before going into the SNF. And one of the things that we're hearing from other ACOs is that the process really needs to have some very strict controls in place, and that rather than training a whole lot of people on how to screen for who should be able to go to the SNF under the waiver, or who goes into private nursing care because they have much longer term needs, that it really needs to be just a handful of people providing that decision, of course under the direction of a physician. So again, we don't have any direct experience on the paramedic side, but as we look at diversion programs, we're hearing some pretty consistent themes about control of the decision-making process.
So I'm going to, again, just go in a different direction. I think we need to do a much better job of educating the community on Narcan and the duration of time that it works. But I also believe we need to sit down and create a collaborative with the folks in the community, because we're not doing anything with the rapid response teams. We're doing very little with community agencies, so that we can go ahead and have a better way in which to share information. We call this the Prince approach. You do know the reason Prince died is because he had Narcan and he was supposed to be admitted, and then he died. We don't even touch that kind of information with the patient population that is in need of that support. The other thing is we don't have behavioral health folks as our partners. How many of you, if you're in a physician's organization, can actually sit down with a battery of individuals to start talking about behavioral health issues, mental health issues, and substance abuse issues? Until we do that, and until we get that data, and until we're able to bring people to the table to have that conversation, we're going to continue to have challenges. So, Dr. Simmer, if you're looking for folks to go ahead and pull together and have that kind of a group, I'm sure the three of us would love to be a part of that.
Dr. Simmer, thank you for the kind words. We have not had any experience with that, but something we would be interested in pursuing in the future.
Question for Terrisca. You have a wide geographic area, and I'm sure you have some smaller towns, one-horse towns, and I'm sure you have higher cost areas that physicians are kind of obligated to use because they have no other options. Or how do you manage that? How do you manage when you know the costs are really high at one system versus another to control your costs?
We have not prescribed what the QROs should do or the physician organizations should do in that case, other than to send the patient to the place that they feel is the most suitable for their care needs. Certainly, folks up in Cadillac have fewer choices than, somebody in Metro Detroit. Going back to the SNF example, there are very few skilled nursing facilities in rural areas, and they have longer length of stay and higher cost, and how do you grapple with that? But at the same time, you want to keep that person, close to their community and their family. And so we really, as an ACO, we do not dictate or set policy at an ACO level. We allow the QROs and the physician organizations and the providers to make the ultimate decision.
However, when we're looking at diagnostic testing, that is, for at least our organization, extremely important way in which to reduce costs. So we do redirect individuals from hospital systems into freestanding facilities, and we make it very clear that the quality is the same, but the cost is tremendously different. So many of the activities that we're involved with, we really do go ahead and redirect into those organizations that we have agreements with that are willing to go ahead and look at cost from a different perspective.
Well, we don't have as large a geographical area as POM. Both Monroe County and St. Clair counties are obviously much smaller. There's, in places where there's only one hospital, you can't do much about the hospitals, but in most areas, in terms of SNFs and others, there are alternatives. We meet with each of the SNFs in the area to try to find out the ones that will cooperate. We communicate that to the doctors. The doctors do not always listen or will follow it. Some of them have long established referral patterns, but in some cases we can get them to see the vast difference in the length of stay. And especially in SNF, that's a very easy measure because 20 days, 30 days, that doesn't take complex math. And it's a process over time. And the other thing that we have found that if one SNF in an area, for example, suddenly sees a slight increase in business from our ACO, suddenly the other SNF can find ways to cut their length of stay. So it's partly just staying on top of it and doing the best you can under those circumstances.
Thank you. Oh, another question?
There. Can you guys hear me? My name is Madhu from Ready Minds. We're a technology company. In your opinion, there are several software and analytic solutions that are out there to support population health management. In your opinion, what are some of their shortcomings? What can they do to improve their effectiveness?
Hey, Mark, that's an answer you can go ahead and provide. I can simply say this. When we're investigating any tools that we purchase, any IT tools, we have a great IT group that reviews and analyzes before a decision is made. So it doesn't happen overnight. If you're looking at identifying one population health tool, I always ask the question, where the heck were you 10 years ago when we started this and we had to do all of our own work? So there are a lot out on the marketplace right now, and I think everyone needs to do their own due diligence to figure out what their needs are and what they want. Perhaps ours is different than an ACO's, but then again, each one of us has a robust IT department and also a robust QI department that would make that recommendation to the board.
Yeah,
You don't have anything yet?
Yeah, I think one of the issues, there's lots of vendors, and many of them have very good products. They tend to say that this will work for whatever your organization is. We've got 3 really different organizations. What's going to work for me is not going to work for them. So kind of don't overpromise, and understand that almost every application is going to be specific to that group, and it's really got to be customized. And we've seen some really good off-the-shelf stuff that has 75% of what I want, and probably 75% of what they want. It's the other 25% that's going to sell it, and you're going to have to customize it for each individual group if you're going to meet their needs.
Yeah, and just one other thing. All of the organizations, the POs and the ACOs, we've reached a level of intelligence now as to what we need. So it's not that simple to come in to sell us an apple pie minus the apples. And we've learned that over the years. So the level of sophistication is quite significant now, and it will continue to evolve and even improve as time goes on.
Thank you. Thank you. Are there any other questions? Very good. Thank you all very much for your time.